Okay, good morning, everyone, and thank you, Greg, and thanks to everyone for having me. It's always nice to come to Hopkins. As Greg said, I'm going to talk about technology and healthcare from the consumer side, with a particular focus on older adults, because that's where we do our research, and also older adults use healthcare services and systems a lot. I will be mentioning a couple of exemplary research projects, and I want to acknowledge the support of NIA for supporting those projects. Okay, so what I'd like to do, I'm going to provide a very brief overview of our CREATE Center. The reason I'm starting with that is it really shapes the context for the rest of my remarks and where I'm coming from. I'll then provide some background on current both healthcare and demographic trends, also to provide a little context. Talk about the role of technology in healthcare and what we perceive of as current barriers, both to technology access as well as use, particularly among older consumers. Provide some examples of some things we're doing and have done at CREATE in this general domain. And then I will talk about the importance of something Greg already alluded to, was a user-centered, multidisciplinary design approach, which is what we espouse in our CREATE Center. So CREATE is a multidisciplinary center, and it involves the University of Miami. I direct CREATE. These are just the key people in CREATE. There's teams at each of the schools. Florida State University, Georgia Tech to some extent, but now the University of Illinois, because Wendy Rogers has moved to Illinois recently. And it's a multidisciplinary center that really focuses on older adults and their interactions with technology systems. We've been fortunate enough to be funded for this from the NIA since 1999. So as someone said at dinner last night, we focus on older adults, and the CREATE team is also aging. So there you go. So what are our overarching goals of CREATE? And these really haven't changed over the years. It's really to ensure that older adults are able to access, which is important, successfully adapt to and use both existing and emerging technology systems. At the same way, these two objectives are obviously closely intertwined. Ensure that the potential benefits of technology are realized by very diverse populations of older people. And we look at these issues across a broad range of technologies and domains and user groups. And one of the domains is obviously healthcare. This is our model that we espouse to, and I put it here. It's really a person-environment fit, human factors basic model to show you that that's our perspective when we're looking at technology systems, that you really have to use a systems perspective and not only just focus on the technology and what it can do, but also think about the user who's going to be interacting with that technology, their characteristics, needs, preferences, and abilities, the tasks that they'll be performing using the technology, and importantly, the context or the environment in which all those interactions will take place. And the notion that we have in CREATE is there has to be a fit among all of those components, okay, if in fact the potential of technology it should be realized and people are going to be able to use it successfully. Okay, so that's kind of the mindset that we use in our research efforts. In terms of social and demographic backgrounds, as you well know, there are certain changes in healthcare dynamics that are happening right now where we're moving towards more of a partnership model of care, meaning that consumers are supposed to play a more active role in the management of their own health and in decisions that they make around their own health. There's also a trend from inpatient to outpatient care, Many more people with chronic conditions, especially older adults, are being cared for at home as opposed to clinical settings, and a great deal of care and support for that population is provided by family members. I believe that family members serve as one of the largest single support for older adults currently in the United States, which is why we just had a National Academy of Science Consensus Conference on family caregiving for older adults. Family care, oh, I just said that, okay. And a third and very important trend, which I think is one of the reasons that we're here, is, as Greg said, that technology is playing an increasing role within the healthcare domain, and this trend is not going to go away. I think it's only going to become more significant. And as we'll see, technology in healthcare is used, and I'm looking at the consumer end now mostly, for a lot of activities, tasks, and purposes. At the same time that this is happening, another trend, which I'm sure you're all familiar with, is population aging. And something very significant about population aging is the increase in the oldest old. If you look at our demographic projections, the blue line here represents people over the age of 65, and that percent of our population is increasing dramatically. I think what is perhaps more significant is the green line, I think it's green, yes, is the green line, which is showing you the increase in people over the age of 85, which is referred to in the literature as the oldest old. Why this is so pertinent to today's discussion is that as one gets into these older cohorts, the likelihood of having one or more chronic conditions increases dramatically. It doesn't mean that people aren't aging successfully, but we have to be cognizant of the fact that it's very likely that they'll have some type of chronic condition or illness, such as diabetes, cancer, cardiovascular disease, or dementia. This is just some data from 2012 that shows the percentage of older adults reporting at least one chronic condition, if not more. And here's some very recent data on the incidence of dementia worldwide, not just in the United States, which you know is a very big issue in the healthcare arena right now. And if we look at healthcare expenditures in the Medicaid population, you can see the increase as we increase through the cohorts. Okay? So I think population aging is really something when we're thinking about healthcare and we're thinking about healthcare and technology, we have to really focus a lot of our attention, I think, on the older adult population. So what role can technology play in meeting our current healthcare challenges? And again, I'm primarily looking at this from the consumer perspective. Certainly enhanced healthcare, and this is both the consumer as well as the provider. There are lots of technologies out there, telemedicine technologies. There's a lot of new things happening in monitoring and sensing technologies, in online support groups, electronic health records, etc. And we're going to see more applications like robotic applications, which are developing here increasingly, especially in the very near future. And it also provides people, and this is pertinent to one of the points I made earlier about the partnership model of care, technology, things like websites really provide people with a lot of access to health information and resources, which is both good and bad at the same time, depends on what the source is. And there are lots of assistive technologies out there, and as I said, technology can be used to support family caregivers, and also is being used to manage chronic illness in home settings. And this, I think, is an area, you know, I wouldn't say a lot, but there's been considerable research on things like people using the internet to get health information and on other kinds of telemedicine applications. I think the one thing that we need to focus more attention on is people using complex technologies in the home as part of their own health care or as a caregiver who is supporting someone with a chronic illness. And many times those technologies are extremely complex and people have not been trained to use those technologies. We just send people home, give them the technology, and expect that everyone's going to be able to use them and maintain them. These are just some examples of some technologies that are currently there, where there is even a robotic and assistive robotic application. And of course, there are lots of PHRs, which are increasingly being used in healthcare settings. So what do we know about aging and technology? If we look at this very generally, okay, and I've said I'm focusing on older adults. One is, it's still shocking to us that many older people are still unaware of technologies that are out there or of the benefits of technology. We run a lot of focus groups in CREATE before we do our research or design something with older people, and it's still shocking how many of them don't know about the internet, what the internet is for, what they can do using the internet. It is quite surprising, especially when we're looking at people from the lower SES cohorts. They're less comfortable and have less efficacy using IT than younger adults. I don't have the slide with me, but we have 20 years, about 20 years of data from CREATE, and close to 20. And we've been measuring, as part of our core assessment battery, attitudes towards technology for all of these years, and we just analyzed some data very recently. A lot of our work is also cross-sectional, so we can do comparisons between younger adults and older adults. And it was very shocking to us that even though attitudes and comfort using technology and self-efficacy, meaning I'm able to master the use of technology, even those attitudinal aspects have increased over the years by older adults, there is still a significant age difference. Okay? So we're still finding that even today in 2017. But older people are not technophobic. They perceive IT as valuable, and they are quite willing to use it if it is well designed, and that's a big if, and they receive the appropriate training, which is another big if. They can learn new things. They may need more support, more environmental aids than younger people. This is all, other people have found this as well. I'm just highlighting some of the stuff we've gotten from CREATE. And they also have less access to technology, especially people in the older cohorts, 75 plus, those in rural locations, or of lower socioeconomic status. Here is some very recent data from the Pew Internet and American Life Project, and it's looking at both internet access in general and broadband access, and we can see that there is still, and this is from 2016, okay? There is still an age-related digital divide. And the thing about broadband is quite disconcerting to me, given that many services are now being put online. Things like Medicare, Social Security, other sources of benefits, etc., are now online. And if people don't have access, they're not going to be having access to those services. We see similar trends for smartphone adoption. Okay? I'm not talking about cell phones. Okay? Most people have a cell phone of some sort. I'm talking about smartphones. And the significance of this is, again, we're designing lots and lots of things now and assuming that people have access and can use mobile devices. Okay? So the age-related digital divide still exists. And I looked at some data yesterday, some even more recent data, and the trends are still the same. So what about the use of healthcare technologies? I did a little literature search preparing for this talk, and certainly use of tablet technologies. There's some recent data that show that older people who are in clinical settings and are using a tablet are satisfied with their use. They're able to use it. In terms of patient portals, there is a very small amount of research on this topic. And a study that Turner did in 2015, sample was relatively small. It was only 75. These were community dwelling adults, and found that only about 20% used or had ever used a patient portal. They liked it. They found it valuable, what they could do with it, but there were barriers to use, okay, including things like lack of computer skills, which is not surprising, cost, and lots of concerns about security, privacy, and then, of course, usability issues. In terms of telehealth and wearables, my colleague in CREATE, Neil Sharness, has looked at this somewhat, and again, found that older people are willing to adopt these kind of technologies, but again, they have concerns about privacy, and with wearables, lack of physical comfort, wearing something like a Fitbit. Okay. And in health technology uptake, my colleague Richard Schultz at the University of Pittsburgh found that, again, this is a recurring thing, that people, older adults, have privacy concerns. They're afraid about reduced social interactions if they rely on technology, and really concerned about having the appropriate training and being able to maintain the technology. So I want to just show you briefly a study that we did. This was actually my student, Jessica Taha. This was some of her dissertation work, and another study that we did in New York. I'll just highlight some of the results. And this was looking at people, these were actual consumers, okay? In the first Taha study, I'm going to expand on this in a moment, we used a simulated personal health record. In the second study, we actually had consumers come in and use actual PHRs that are available and on the market. Okay. Our sample ranged in the first study was mostly 40 to 85 years. Most people in that sample were minorities and of lower socioeconomic status. And in the second study, most again were minorities and of lower socioeconomic status. And what did we find across both studies? These were people, I'll show you an example in a minute, from the Taha study, have actually interacted with the personal health records to perform typical health management tasks. We found that they liked them, and they thought that if they could use them, it would really facilitate their ability to do things like make appointments, reorder their prescriptions, look at their health data, etc., and understand what was going on with their health. However, in both cases, we had lots of usability problems. One was, because of our particular samples, was the technical language. Okay. People commented that they had a really hard time understanding the language that was on the system because it was highly technical and for the most part designed for people who had medical expertise. There were also usability problems, difficulty navigating through the systems, finding information. Last thing, which I'm going to focus on when I show you the Taha study, was lots of problems interpreting graphs and charts. Okay. So let's look at the Taha study in more detail. This was really what we were focusing on was, can older people use a patient portal to perform common health tasks? We were really interested in looking at the relationship between individual characteristics, including cognitive abilities and health literacy on performance. And why are we interested in that? Because we think if we understand these kind of relationships, it gives us some ideas about how to redesign these systems, what kind of interventions are needed. For example, if they're too cognitively demanding, what we will then do is try and design them to reduce the cognitive complexity of the system. And of course, we wanted to look at usability problems, given that our perspective is from human factors engineering. So we actually built a simulated patient health record, and we modeled it on Epic's MyChart. Okay. The reason we built a simulation is because this was a study and a dissertation study, and we didn't want to be fooling around with actual patient records. Okay. We developed 15 tasks. We worked with our clinical folks at the University of Miami that were core things that people do using a PHR, managing their meds, reviewing and interpreting their lab results, and some health maintenance activities. And we purposely designed tasks because Jessica had a particular interest in health, in numeracy, okay, our ability to manipulate numbers and understand mathematical operations, which we think are very critical to things like interpreting your lab results. We made sure the tasks spanned in terms of their complexity on the numeracy demands. Okay? So they range from very basic things like knowing how to add to more computational analytic understanding what an odds is. There's 1 in 10 chance that if you take this medication, you're going to get this side effect, which is a much higher level of numeracy. Okay. This is what the simulation looked like. Okay. And here's an example of test results that people had to interpret, just to give you a flavor of what we built. Here's our summary of findings. Our sample ranged in age from 40 to 85 years. I already told you that they were primarily lower socioeconomic status. They liked the portal. Now, this wasn't an actual portal, but it looked a lot like it at the time. They perceived that as highly valuable, but they really had problems completing the tasks. Now, there's another thing about the sample that I didn't put up here. All of them had computer skills. Okay? These were not computer naive participants. We purposely recruited them so that they had experience with computers and knew how to navigate the internet. They had a really hard time understanding the health information, okay. Interpreting the lab test results, for example, are my values out of range, understanding medication schedules, interpreting graphs and charts. And when we did some regression analysis, don't forget, we gave them a battery to measure a lot of abilities like cognition and literacy, etc. What we found was that significant predictors of their ability to perform these tasks were prior computer experience, which is not surprising. Okay, we did have people who ranged in their experience with computers, even though they all had some experience. Cognitive abilities, okay, played a very big role. Okay. Literacy and numeracy. And another, most, I think more than 50% of older adults have below basic health literacy skills. Okay, so these are very, I think, really important findings when we're thinking at design of systems. Numeracy, some of the folks were not able to interpret a greater than sign or a less than sign. Okay, didn't understand what the boundaries were, had a really hard time interpreting the graphs and bar charts. Okay? And I think this goes a long way in talking about what we take for granted when we're designing these systems can be challenging for many consumers. Okay? So, what are some of the general barriers to technology adoption? Okay, certainly lack of knowledge and awareness, lack of training and technical support. Cost is still a big driver. System complexity and what we like to call feature creep. Okay, we're adding more and more and more bells and whistles onto our technical systems, and sometimes simpler is better. Usability is still a big problem, and also continual changes in technology. This is just the evolution of a cell phone. Okay? And now we have iPhone 8, 8X, I think, and 10. Right? And I notice that my 6 is starting to act up, and I'm wondering if it's an Apple conspiracy that is driving me now to buy an 8 or a 10. Okay? What's also amazing is that they're used the least from what they're supposed to be for, which is having a conversation. So, this is just a funny cartoon on usability, and it sometimes, I think, is a real kind of frame for what many designers think when they're designing technology. They really don't think about the user, okay, because they don't really interact with users. Okay. So how do we work around this problem? Okay, I really think that we have to take a user-centered design approach. And this means understanding user characteristics, needs, preferences, demands inherent in the use of the technical system. Like that PHR study I showed you, we were able to uncover a lot of demands when we actually tested the system with users, such as numeracy, literacy, etc. I think we have to use ecologically valid research protocols and focus on actual tasks that people are going to be performing when we're doing our user testing. And something near and dear to my heart, and this is what our Center on Aging looks like at the University of Miami. I think this kind of work really requires multidisciplinary research teams. These are very complex issues, okay? And we have to look, we can't look at them from one lens, okay? We have to have a multidisciplinary team approach that includes clinicians, designers, human factors engineers, behavioral sciences, etc. The mix depends, obviously, on what you are looking at and what you're designing. And I think something else that's important is the continual involvement of users in the design process. There are lots of guidelines out there. Okay, if we're going to talk about older adults and use of technology, I'm not going to spend time on this, it's boring. But there are lots of guidelines that are available for auditory displays, cognitive considerations. So it's not like when we have to start from scratch when we're designing their systems. There is a solid evidence based on ways to make things more usable for older people, and CREATE has really done a lot in that area. So I want to just highlight in closing another study. This is not really focusing on healthcare, but the reason I'm showing it to you is it does provide an example of how we used a user-centered design approach. And this was a cross-site project, CREATE, meaning we did it at Miami, Tallahassee, which is where Florida State is, and Wendy was at Georgia Tech at the time, so we did it also in Atlanta. It was called the Prism project. And we designed a computer software system that we called Prism. I'll show you it in a minute. We wanted to examine the impact of this system on our main outcomes were social isolation, social support, and well-being. And then, of course, look at access to the system on computer self-efficacy, other types of technology adoption. We did this study, people had access to the system for a year, so we were able to actually gather longitudinal data, which is not done a lot in this type of research. And we looked at usage patterns over time. Okay. It was a registered cross-site randomized trial. Okay. We registered it with clinicaltrials.gov. Our target, there were two conditions. Okay. Prism C, people got the computer with the Prism software in their home. Prism B, they got a notebook binder with content very similar to what was on the Prism system. Okay. Our target population was older adults who lived alone. They were 65 and older, and they were at risk for social isolation. Okay. Originally, we were going to recruit 100 people per site. Neil at FSU had a little trouble with recruitment, so we over-recruited at Miami. So what was our design approach? It took us about 1.5 years to design Prism, okay, because we involved older adults throughout the design process. We had focus groups. We did pilot testing with our prototypes on more than one occasion. The PIs did heuristic analysis and usability review, redesign, re-review, and we pilot tested our training program, which was really important. Because we found that it wasn't training on the use of Prism that was problematic for our participants. It was training on how to use the mouse and some of the basic Windows operation. Had we not pilot tested the program, People would not have used Prism, not because of Prism, but because they couldn't operate the mouse and use Windows. So we had to revamp our training program accordingly. This is what Prism looked like. Okay. That was the home screen. It was very easy to use. To access any of those features, you simply touched, it was one click. Okay. So we had a classroom feature that we designed. They could go on email. The email had a buddy feature, meaning that when you signed up for the study, you could agree to be a Prism buddy, and your email would be listed in the buddy part tab with 3 hobbies of interest. So we thought it might be a way for people to make new email buddies, photo sharing, games, etc. And you could, that banner on the bottom, the home was there, always present, so they could always go back home. Okay? And every day they got a new picture and etc. It was a very neat system. Okay? So what did we find? Oh, this is our sample, and I want to stress something here. Our sample ranged from 65 to 98 years of age. So I think 33% of the sample was 80 years and older. Okay. All of them lived at home alone. They did not have computers in their homes. Okay. And they had none or very minimal computer experience. Maybe they interacted with a computer with their grandkid or at a doctor's office. Okay. But these were not highly skilled computer users, which is part of the reason Neil had trouble with recruitment, because that was one of our inclusion criteria. And Tallahassee is more of a university town, so people tend to be a little more sophisticated as compared to some of the older adult populations in Miami. We had 40% of the sample was ethnic minorities, and the majority were in the lower socioeconomic income strata. Okay. I will say that because of our inclusion-exclusion criteria, these folks could not work or volunteer more than 5 hours a week. They couldn't be involved in community activities. I mean, we really were trying to get folks who were isolated and perhaps could benefit from the system. Recruitment was a challenge. We had to really be very innovative in our recruitment strategies. And I think that sometimes this is overlooked in behavioral intervention studies, the challenges and the effort that is associated with recruitment in these kind of projects. Okay. So what did we find? Our main outcome paper just came out, and the gerontologists were very excited about it. We were able, because I think of the way Prism was designed, right, and we spent so much time on the user-centered design approach, we were able to train everyone on the use of Prism. Okay? We had, as I said, 33, I think, % of the sample was 80 years and older who had never seen computers before or used computers before. We trained people individually over 3 days in their own home. And we got changes in our both primary and secondary outcomes, which we're thrilled about. People who use the system have felt more social support. They reported less loneliness, higher well-being. Okay, we got whoppingly significant changes in computer proficiency, in attitudes towards computers, and these we also have a lot of qualitative data that we're just starting to unravel. This is what they liked about using Prism, that they could reconnect with the past. They'd go on the internet and search for their hometown. They could reconnect with friends, family, communicate with their grandchildren. So I think it was a success in that a lot of things they liked about Prism were in fact related to our goals of reducing isolation and enhancing connectivity. The things they use most, the other data we're just starting to look at now, is the actual usage data, because we collected real-time use of the system. The features they used most were email, internet, and surprisingly games. Okay? They really like the games. That's good or it's bad, I'm not sure. And we got, people did, we had some people who dropped off, but on average, people continued to use Prism throughout the duration of the study. So here's just a quote. I kind of like this. This is from one of our participants. Of course, she consented to have the quote here. I highlighted the real reason that she liked Prism was because it gave her connection. She was lonely and alone, and this gave her an opportunity to play games, to reconnect. So I think that overall it was a success. So where are we now? We're just started the Prism 2 trial. Prism 2 has expanded functionality. We've totally redesigned, not totally, but we've redesigned the homepage a bit. We've added new features. We have a learning feature now, which has many tabs to it. We have a dedicated health and wellness feature. We have video conferencing now, so people can Skype. And it's also available in English and Spanish, because in Miami, we couldn't recruit many people because a lot of older adults in Miami, especially current older adults, Spanish is their primary language. So now the whole thing is both in English and Spanish. And we are kind of in a way running 3 mini RCTs because we're evaluating Prism 2 in different contexts. FSU is looking at it in rural locations. It's certainly not what we would do in Miami, but Tallahassee has access to a lot of people who live in rural locations. Georgia Tech in senior housing units, and at Miami we're looking at assisted living facilities. I don't have any data to share. I think we've each enrolled about 5 people so far. Okay, so we just got into the field. We did use the same design approach for Prism 2 as Prism 1. Okay. So, in conclusion, in research needs, I really think that healthcare technologies certainly have a lot of potential. I think we're all in agreement there, of being beneficial to not only providers and patients, but also to family caregivers. I think design of these technologies must include multidisciplinary research teams. We have to consider the context in which they'll be used and involve representative groups of users. We did a study. We used technology a lot to deliver caregiver interventions. Okay? And we did a study several years ago where we used a technology that required home internet access. And we designed it and pilot tested it, and shame on us, we didn't think about context. We just assumed our caregiver populations, who were African American, Hispanic, and Haitian, who lived in Miami, we assumed that they would have internet and it would be no problem. Well, when we went to install the system in their homes, not one single caregiver had internet. So before we were able to install the intervention, we had to work with the telephone companies to get their houses wired up, if you will. So you really have to think about context and constraint of context. Involve representative user groups, and I think there's a lot of space for research in this area. I think it's kind of in its infancy stage. We have to think about the cost effectiveness of technology-based approaches. What are some of the advantages or disadvantages of more advanced technologies relative to simpler technologies? As I said earlier, more complex is not always the answer. We have to think a lot about privacy and preferred formats for monitoring. If you remember when I put up that earlier slide, a lot of concerns that folks have about these technologies are around the issue of privacy and security of sharing information. We need a lot more data on usability and longitudinal impact. Most of the research that's gone on in this space has not looked at long-term outcomes. Okay? And I think we have to think about how do we integrate technology in clinical settings with other clinical practices. We can't look at it as standalone. It has to be part of and well integrated into the larger system. And just a plug for CREATE, I talked about design guidelines before, and we have written several books on this. Our Designing for Older Adults, we're right now in the middle of working on our 3rd edition. Okay? So data is out there to guide the design process. Thank you very much.
Thank you, Sarah, for a wonderful talk, which I really do think hits exactly the theme of the day. We have a few minutes for questions, so I'd invite the audience to ask questions. If I could ask, we are live streaming, so if you could come up and use the microphone so that anyone on the live stream can hear you as well, that would be outstanding. But please step up for questions. Just while people are getting themselves organized, I had a couple of things that I thought of.
Okay.
Well, so the first question, probably the obvious one you get, is are we really just in an interregnum with older adults not being familiar with technology? And is it the case that, in fact, Ed Schlesinger and I were discussing this, in 10 or 15 years when, we're entering that era, we're obviously much more comfortable with technology. So is it a problem that will be solved with time, or do you think it's going to be with us?
We get that question a lot, and I think the answer is I think it will be a problem that will be with us for two reasons. Technology is dynamic and not static. It's constantly changing, and people continue to age, and there are changes in abilities that happen with age. I think we can minimize some of the current challenges if we learn lessons from what's going on currently.
One of the challenges that we've seen in some of our work where we deploy technology, is that the people have been changed by it, which your study shows. Do you remove the technology from their home? Do you let them still use it? And then are you responsible then for doing tech support? Those kind of things. How do you address this challenge for doing that kind of?
For the Prism trial, we actually let people keep the computer. We couldn't no longer pay for their internet costs because we're a university doing research. I'm not AT&T. But we had a protocol where we actually, for people who were interested in staying online, of actually going into their homes and working with them to help them set up their system. There was a possibility that Prism 2 was going to become available on a broad Prism 1 on a broad spectrum, but we are certainly hoping that for Prism 2, that's one of our goals. And it's not just going to be a research study, but it'll evolve into something that's actually available.
Thank you again for the great talk. I think you laid out very well in the tech, especially healthcare. Just wondering what your thoughts were on some of maybe the, let's say, pitfalls of technology. I think of this of my 87-year-old grandmother who tries to maintain a Facebook page and is, checking email, and the number of, let's say, friend requests that she has on Facebook to people that she's never met before, but she's often very, let's say, apt to accept as friends, or the number of phishing scams that she gets in her email inbox, and how do you deal with that? I mean, I typically go through and delete all these, but when you're not there, how do we train or make aware of these type of things for individuals as we do try to push technology to them as well?
I think you're right, and I did not speak about this, but there certainly are, let's say, challenges associated with technology. I don't think technology is necessarily the answer. I think technology can augment activities, augment services, etc. In terms of things like the phishing and so forth, one of the things that we've built into Prism 2 is actual training on these kinds of issues, and we're also about to start another study with the University of Pittsburgh looking at factors that predict financial exploitation of older adults, and I think one of the big things there, of course, is email and the internet, etc.
So I had one last question. It's actually inspired by your earlier question, which is, so you look at something like Prism, and it seems like it was really quite successful. It really changed people's lives. And so you'd like to see that scale out into the real world. So what's the path to scalability? How does this go from a research study to something that becomes a broad-based application or an intervention?
Well, I think there has to be collaboration between the research team and industry, particularly the IT industry. I know for Prism 1, we came very close. We were working with a small business, and we even got the lawyers from the 3 universities to agree on the contract, which was harder than designing Prism, I will say. But that was a small business that kind of faltered. So I think I think it's going to require a partnership with bigger fish in the pond, if you will. Thanks. Thank you.